All right. Thanks, everybody. It's always a little bit hard to think about this talk in the context of you've already met with a bunch of other people already today, and you've heard snippets of the things I want to cover. So I'm going to go quickly through, the things that'll be review and try to spend some time on focusing on the novel information. By no means am I presenting a comprehensive list of all of the ongoing studies in this space, but kind of walking you through how I think about this and how I think about whether a particular clinical trial is something that I want to get involved with or that I would recommend a patient go and seek out somewhere else. So we're going to start with the checkpoint inhibitors. So I know you've had a great talk today already about sort of where checkpoint inhibitors fit. But I want to hone in a little bit on a conversation about how they actually work. So I hope you guys will indulge me in this short video.
Our immune system protects us from disease, killing bacteria and viruses. It also helps fight cancer. A T cell is one type of immune cell that does this. T cells have proteins on them that turn the immune system on when it needs to fight infection, and other proteins that turn the immune system off when it is no longer needed. These are called checkpoints. Cancer cells can trick the immune system by turning the T cell off, stopping them from recognizing and attacking the cancer cells. Drugs called checkpoint inhibitors turn the T cells back on. So they can recognize and attack the cancer cells. For more information about checkpoint inhibitors, click here.
Quick overview of how the checkpoint inhibitors work, and everything always sounds better with a British accent. So, and it also had captions in case the sound didn't work, because that's the first time I've actually embedded a video in PowerPoint. So my kids had to show me how to do it. So just to take a little bit of a deeper dive into what we're talking about here. There are multiple different checkpoints in this immune system. It's the whole training camp. It's the whole kit and caboodle that teaches your immune system when to act up against something versus when to say, oh no, this is pancreas. It's supposed to be here. Don't attack it. So 2 of those checkpoints are PD-1 and CTLA-4, and we focus a lot on those because we have drugs for them. We have lots of other checkpoints with drugs that are in development. There's one for something called LAG-3, all these different things. And those are all still being studied for the most part in early phase clinical trials where people with all sorts of tumor types come on. And there's nothing yet, I would say, that's compelling that one of these other checkpoints is going to be the winner and going to have a great new drug that's better than the existing ones. So what do we have right now? We have the CTLA-4 inhibitor ipilimumab. For PD-L1 directed therapies, we have atezolizumab, which had a really good study done with it along with bevacizumab for peritoneal disease. We have durvalumab, which has been the subject of these trials all built around the name DREAMer. And then we have the PD-1 drugs, which are nivolumab and pembrolizumab. And again, you can see here in a sort of still version of a cartoon how the drugs come in. And so they don't really turn on the immune system. What they do is they undo the cancer's ability to suppress the immune system. And as many of you also know, they can cause a lot of different side effects. So this is all came from the Checkmate 743 trial, and that was the study that took those 2 drugs, the ipilimumab, the CTLA-4 inhibitor, and PD-1 nivolumab, and combined that against chemotherapy, and the immunotherapy for most people was beneficial. I put this slide in here just to highlight the fact about toxicity. So these columns here are the immunotherapy, and this was the chemotherapy. And increasing grade of toxicity is increased severity. So we consider a grade 3 or 4 a very severe toxicity, because grade 5 toxicity is actually death. So 3 and 4 are pretty serious. And what you can see here is there were actually more treatment-related deaths, small absolute numbers, but more than twice as many with the immunotherapy. So one of the challenges is that people will have side effects. When we release that inhibition of the immune system, sometimes the immune system then attacks not just the cancer, but it attacks things that should be there in the body. So the question has been, well, how do we improve beyond that? So then there were some studies that looked at combining chemotherapy with one immunotherapy drug. So maybe you get the benefit of the chemo, you get the benefit of the immunotherapy, but not without as much side effects. What you can see here again in that study with the combination is that chemo and immunotherapy was more toxic substantially than chemotherapy. I think if it had been massively improved activity, that would have been more of a conversation. But the differences were there, but they were small. So what this has left us with is in the treatment guidelines, you can kind of do anything. You can do chemotherapy alone. You can do 2 immunotherapy drugs together. Or you can do chemotherapy with immunotherapy. So how do we improve on that? So this is where we come to the current clinical trials. There's a drug right now called volrustomig, and that's a drug that targets both the PD-1 and the CTLA-4 at the same time. And the idea there is that because it has to bind both things, and if you think back to the cartoon, they were kind of separate in space, those 2 receptors. If you have to bring them in close proximity, the idea being that that's going to disproportionately only happen when there's a cancer cell where it's taking advantage of both of those checkpoints. And so normally in the pancreas and the colon and the other places that can get inflamed, you wouldn't necessarily have CTLA-4 binding near PD-1 binding. So by localizing that in one molecule that has to bind both things at the same time, it could have that same effect on cancer with potentially not having the same amount of toxicity. So there's a new clinical trial. It's called Evolve Meso, and that's for folks who haven't yet gotten any treatment, and you're randomized either to get this volrustomig drug with chemotherapy or get standard of care. And standard of care is at the discretion of the doctor that's treating you. And this study is looking to treat folks and then see if by getting the advantage of combining immunotherapy with chemotherapy, but using 2 drugs, but hopefully with less toxicity, if we can still get some of that benefit, but mitigate the complications that can arise from that. So that study is actively recruiting elsewhere, and in the U.S., the first few sites have actually opened and are screening patients. There are also some other recently completed or ongoing clinical trials actually done by many of the people who are here at this conference, but really looking about how to integrate immune therapy sort of around the time of surgery. So there's clinical trials looking at giving immune checkpoint drugs before surgery, after surgery, before and after, combining it with or without chemo, and with or without additional drugs like bevacizumab, which you may have heard about this morning. There's also just a very newly open study that Dr. Ripley is running, looking at immunotherapy around the time of surgery. So that's where the conversation has focused, where while we're waiting for this new trial, the Evolve, to accrue, and also to figure out, remember, to keep in the back of your mind those other checkpoints that people are developing drugs for. But I think that really summarizes most of what's going on at this moment in time related to checkpoint inhibitors for mesothelioma. So the second thing that folks asked me to touch upon was targeted therapies. So the way targeted therapies work, it's a little bit of a misnomer, right? Even when you get a chemotherapy, it's targeting something, right? But we use the sort of euphemism of targeted therapy when we're going after something that we think is only or excessively disproportionately expressed in a cancer. And so what you can see here, there was a collaborative effort called the Cancer Genome Atlas, where hospitals all around the world, through the generosity of patients, donated some tissue, and it was all profiled and sequenced and looked at all of the different genes we know to look for to see what kind of mutations are there, what kind of genes are deleted, abnormal, and can we go after some of those abnormalities, right? So if we know in a particular person there's a messed up expression of a certain gene that leads to a misshapen protein, can we then come and give a drug that targets that misshapen protein? Or somewhere else, if there's a loss of a gene, so you don't make that protein, and therefore you become totally dependent on some other pathway, can you then inhibit that other pathway and then make that cancer cell uniquely susceptible to your intervention? So these are the data as we see them in these publications and projects that we participate, looking at different profiles of patients and the gene mutations. And so these are looking at genes that actually have an alteration versus here there's more or less expression of a particular gene. So one of the pathways that really shook out from a lot of this research, and there's been a lot of focus on over the years, is something called the Hippo pathway. And it's a cascade of signals, a lot of which has to do with something called NF2 or Merlin. But here's a little kind of graphic. But basically what happens is this all cascades down, all of this signals competing in the cell for attention to basically communicate, should this cell copy its DNA and divide and continue to grow? Or are the signals overwhelming that it should just stay as is? The ongoing copying of the DNA and cell division, that's what makes a cancer or any cell in the body grow. So all of these pathways you may be able to see here kind of come down to something called YAP-TAZ and TEAD. And those are things that actually engage with the DNA and the proteins involved in unwinding and copying the DNA to either turn that process on or to block it. So there's been a lot of focus now on looking at if we can inhibit these types of proteins and enzymes. So there's one drug that's been reported recently, and it's still early. It only has the letters and names. It's called VT3989, and this was presented at one of the meetings last year. And this drug actually had a substantial effect on mesothelioma tumors. So this is what we call in research, we call this a waterfall plot. So places where the bars go up are showing you the amount a tumor is growing, and the places where the bars go down show you the amount a person's tumor burden is decreasing. And what you can see here is that there were a fair number of folks who had tumor shrinkage, and there was actually people with both pleural and peritoneal disease who had their cancers shrink. So this has generated a lot of interest, and there's actually a lot of other molecules in this space. So I looked this week to see, in addition to the drug from the company Vivace, which is the VT drug, there's all of these other 5 drugs from different companies, all in slightly different clinical trials, some of which are focused on mesothelioma, some are focused on tumors that have alterations in this Hippo pathway that ends at the bottom with the YAP-TAZ, but they're all studies I am keeping an eye on and I think are interesting for folks with mesothelioma. And certainly there's additional new ones that haven't launched that are definitely in development and in conversation with many of the researchers about how to best design studies in this space. So one of the other common alterations that we see in mesothelioma is loss of this gene called MTAP. Again, another cartoon that you can see here, but basically MTAP does a very, very critical function in cell cycle signaling. And when you lose MTAP, you become entirely dependent on the backup mechanism, which is done by a molecule called PRMT5. So if the cell doesn't have MTAP and it's totally dependent on PRMT5, and then we give a PRMT5 inhibitor, we can shut that cell down, hopefully. So there's a whole space of drugs that are targeting PRMT5 for mesothelioma. So I'll show you pictures from 2 patients that received this drug, Mirati 1719, a PRMT5 inhibitor. And what you can, and I tried to show you here, but this is what scans look like at baseline here on the left. So this is, you have to imagine the person sort of lying there with their head, and the left and the right are on the opposite side. So this is the left side of the person's body. This is the right. This is the front of the chest. This is the spine. This is the heart and the aorta and all the things that are supposed to be there. But this sort of gray blob with the red arrow, that's the cancer growing. And what you can see here is in this person, they got treated with the Mirati drug, and then it really, really shrunk down, and you can hardly really see anything in that same space. And similarly, a different patient on the same study had this growth of an abnormal kind of area here where this red arrow is, this sort of gray blob again. And here it's not gone, but it's definitely shrinking. So this drug was actually recently acquired by a bigger pharmaceutical company, Bristol Myers Squibb, and they're in the process of trying to figure out what their next study for mesothelioma is going to look like and where they're going to focus and how they're going to develop it. But I think this is very encouraging data for mesothelioma. And then the last thing I'm going to talk to you about is something a slightly different kind of perspective on targeted therapies. I hope you'll indulge me. So one of the things we think about, and often is my mentee who works at Memorial Sloan Kettering, but one of the things that he and I have been working on for quite some time is figuring out, well, how can we iterate faster, iterate better? And one of the ways to do that is to build better models. So what we've done over the past 9 years now is I've been collecting, again, through the generosity of patients coming to us for care, but at the time that someone's having a biopsy, getting an extra little nip of tumor. And then we take that to the lab and we try to grow it in a mouse. And so we can create a model of Mr. Smith's tumor in a mouse, and then we can preserve that, we can replicate that, and we can test some of these hypotheses that we make. Like if you have this mutation, then that drug might work. And we can create actually a huge library of different tumor system models with all sorts of variations and combinations of this mutation with this deletion. And so we can go when we have a question and go to our library and say, hey, I want to know if this type of a drug, let's go back to that Vivace drug. If Vivace drug seems to be working in NF2 mutated mesotheliomas, but what if there's also deletion of this gene? Will that respond or won't it? And we can actually start to study that and probe that in these model systems that we build. So one of the interesting things we found related to something called CHOP2, which has been talked about and studied in lots of different cancers, but not so much until recently in mesothelioma. And what you can see here are just some ways that we think about when we induce the expression of TROP2, what happens to cells, and when we suppress it, what happens. And what we were able to show in these mesothelioma models is that it really is important in the development of cancer and then the propagation of cancer. So then what did we do? We took a drug that targets TROP2 and we tested it in these mice systems that we had built. And so these are the types of experiments we do where we measure the volume of a tumor in a mouse. And so you can see here's just the mouse without any special treatment. Here's the mouse in red who gets a chemotherapy called gemcitabine. And then here in green, you can see the mouse when they got treatment with this drug called sacituzumab that targets the thing we're looking at, which is called TROP2. So, and we were able to show that even in tumors that didn't express a lot of TROP2, that inhibiting it was meaningful in terms of stopping the cancer from growing. I think what's interesting here is that you don't really see regression. which is a feature of how some of these models work and the way the mice are raised and grown and sacrificed. But you definitely see here some slowing of the growth. And here you actually see it really stops growing and that persists. So that for us became the justification to go to companies that manufacture drugs that target this and say, hey, we have this really interesting preclinical data, right, from a living model. We can replicate in cells, we can replicate in mice that this drug is working, and we think we know in which types of tumors and why. And will you help us run and support a clinical trial? So a trial that is just opening this fall is giving one of these TROP2 targeted drugs. This particular one we're working with is called sacituzumab, and it's giving it to people who have mesothelioma that expresses the TROP2. And that's really how we go from an idea and an observation to bringing a trial to fruition. From support from the pharmaceutical companies, support from the federal government, through a DoD grant. And this is a study that's launching as we speak that should be interesting to follow based on some of the preclinical data. And I think that that's just a really concise example of sort of how we get to the trials that wind up being executed and designed. So I think I'm going to leave it there and just, of course, thank everyone, all the patients, all the families, the caregivers, the folks who, show up and sign the extra forms and let us take the extra punch of a tumor and the extra tubes of blood. And I know sometimes it seems so remote and abstract, but it really does fuel the advances in really important and meaningful ways. And then, of course, thank you to all the people that fund our research, the pharma partners, the federal organizations, and also the Meso Foundation for gathering everybody together and trying to do this work. Thanks.